and get started. Thank you all for showing up at the 8:15 program. I'm very happy that they changed it from 7:30. So I don't know about you guys, but I'm glad that we got that extra 45 minutes. So I'm Amy Zellmer, and this is Dr. Jeremy Schmoe. And today we're talking about brain injury in the vestibular system. So today I am the patient, and I'm going to share my experience of surviving a concussion and how the system kind of failed me. And Jeremy's going to share, what are you going to share?
It's my intervention, my exam findings, and kind of what the care looked like.
So, all right. So just a few things, a few little tidbits. No two TBIs are the same. No two recoveries are the same. Every concussion is a TBI. This is one of those things that I really try to instill in people when I speak at like non-medical conferences, when I'm speaking to parents or kids. A concussion is a brain injury. And, you know, I kind of wish the word concussion would just go away, but I know it's not. So I like to really make sure we point out every concussion is a TBI. Mild, moderate, and severe are just medical terms, and they're not indicative of the severity of the injury or the length of the recovery. And in my case, I have a mild brain injury, and here I am 4 years later, still dealing with it. So a little bit about me. How many in here have I met before? So a few. Do any of you follow me on Facebook? Cool. All right, so some of you might know my story. February of 2014, I slipped on a patch of ice and landed on the back of my head. You can see my little Yorkie Pixie in the picture with me. So I had her in my arm. She had pretty much refused to walk that morning because it was 10 below. And those of you who are maybe not from the Midwest don't understand cold and ice. So it was just black ice. I had no idea. The driveway had an incline to it. And because I had Pixie in my arm, my feet went out from under me. I had her in my arm. The doctor thinks I kind of did this to hold on to her. And I went straight back and landed on the back of my head. Right away that day, I went to my chiropractor, not Jeremy. I went to my chiropractor at that time, and he diagnosed me with a severe concussion, major whiplash. I had dislocated sternum, torn muscles throughout my neck, shoulders, and abdomen, and C4 and 5 damage. And I was told you should feel better about 4 to 6 weeks. So 4 to 6 weeks went by, and I'm still feeling like crap, and I'm struggling. And well, you know, it might take 6 months for you to feel better. 6 months comes along, and I'm still not any better. If anything, I'm actually getting worse. So he finally decides to send me to the neurologist, and the neurologist said, well, let's just give it some more time. So meanwhile, I'm dealing with this plethora of symptoms. So overstimulation, you know, lights and sound, like going to Applebee's was torture. You know, they have TVs playing on every different channel, all the lights flickering, all the noise, the bartender might be blending a margarita, and that's like all I can hear. I can't hear the person 2 feet away from me. So overstimulation, I still struggle with this one. If I'm fatigued, if it's been a long day, this one will still creep in on me. Light sensitivity, most concussion survivors will tell you that light sensitivity is their #1 problem. For me, it was a little bit more, if I would come in from outside, my pupils would take a really long time to adjust. So when I come in from outside, it'd be really, really dark for like 5 minutes. It would take my pupils a really long time to adjust to the light change. Aphasia, this is a word that I didn't know. And the irony there, right? So aphasia is where you can't recall a word. You might be in the middle of a sentence and not be able to come up with the word. And it's like right there, but you just can't get the word. It happened. So aphasia, I would say the wrong word. I remember one time talking to my friend, and we were talking about her lab. She has a black lab, and I called it a zebra. And I got a really weird look, and I'm like, what did I just say? And she's like, you called him a zebra. I was like, okay, that's my brain injury. Apathy, this is another term I had never heard. Apathy it's a neurological condition in which you have no motivation to start something. And oftentimes, TBI survivors are kind of labeled as lazy or non-compliant, and that's really not the case. It's more likely that they have apathy and they just literally can't start a task. I had ice pick headaches. There was no better description than just someone was shoving an ice pick into the spot where I landed on my skull. And I would say for at least 2 years, the actual spot where I landed, like I would have to hold, girls, you'll understand this, I'd have to hold my hair and then brush it. Because I couldn't rub my scalp. It just was so tender. Neurofatigue. This one still gets me. The end of the day yesterday, after being at the conference all day, I went home and just passed out in my hotel room. I like to equate it to a change jar. You might wake up in the morning with $5 in your change jar. And just literally getting up and brushing your teeth might take 50 cents out of the change jar. And then showering and washing your hair might take $2.50. So the first hour of the day, I've already used up $3 out of my change jar. And there's no way to replenish that money unless you rest. So neurofatigue, it can be really debilitating because you just feel like you can't do anything. You're just so exhausted all the time. Dizzy and balance. So I told my doctor, I told the neurologist, I told my eye doctor, I was sent to the National Dizzy and Balance Center in Minneapolis. I was just told I had positional vertigo. Well, I had positional vertigo like 5 years before my brain injury, and this was not the same thing. I could literally be standing still, and like a car could drive by and make me kind of like spin. And I kept telling the doctors, my eyes aren't right, there's something wrong with my eyes. Like, I feel like my eyes aren't working together. That's literally what I said to the doctor. And follow my finger, nope, your eyes are fine. So, it gets really discouraging when you're 15 months into your recovery and the doctors are telling you you're fine and you're not. So, it gets really, really frustrating to keep hearing that. Visual impairment, I just kind of talked about that, how I didn't feel my eyes were working properly. And my eye doctor was the only one who really listened to me because she had been my doctor for about 15 years. So she knew my history. She knew I wasn't like making it up. She knew that something wasn't right, but she just didn't know how to help me. Cognitive impairment, I like to tell the story. The day after I fell, I went to the bank and I walked up to the ATM machine. I had my card out and I got up to the ATM and looked at it. I had no idea what to do with my card. I knew like I was supposed to do something with it, but I didn't know where to put the card or what to do. So I literally turned around and left. At the gas station, the pay at the pump, you swipe your card, and then sometimes it makes you answer like 15 questions before you can pump your gas. And it said something like, enter your zip code and then press enter. But there was no button that actually said enter. And in hindsight, I understand that green button was the enter button. But my brain couldn't make that connection at the time. And so I literally had to get back in my car and I went to a different gas station. That's how like frustrating it was. Cranial nerve damage. I never remember which nerve was it. Was it cranial nerve 7?
Trigeminal
5. So I had cranial nerve damage, which caused the entire left side of my head to always be just like numb. Like when you're Novocaine at the dentist, when it's just about to wear off, like you can feel your cheek, but like it's still a little bit numb. that's how the whole side of my face felt for over a year. And I remember sitting in a conference, and all of a sudden my face had like these little electric zings. And I remember getting up and going to the bathroom and looking in the mirror. I thought I was having a stroke or a seizure. And I remember looking in the mirror, and you know, you're supposed to do the tongue test if you're having a stroke, and I was like, what is wrong with me? And so I went to my doctor the next day, and he explained that it was the nerve. He's like, this is a good thing. He's like, it means your nerve is regenerating. And so every once in a while, I'll still get a little bit of tingling numbness in my face, but for the most part, that one has resolved itself. Short-term memory, what were we here for? So short-term memory, my background is I've been a photographer for 20 years. I own my own studio, and at the time of my injury, it was crazy busy. And I could not keep track of my calendar. I had Google alerts in my phone. If I had a session at noon, I had to set an alert for 11:30, 11:45, 11:50, and 11:55. I'm not even kidding. The doctor thinks I'm making that up. I would forget that fast. Like, I'd get up in the morning, look at my schedule. Okay, I have a session at noon, 3, and 5. Go start doing some work. Ding, I get an alert. Oh, 11:30. That's right, I have a session at noon. Keep working. 11:50, 11:45. Ding. Oh, crap, I have someone coming in. I should go get clothes on. 11:50, I get my next alert. I finally put clothes on, but I don't have my studio ready. Okay, I better go get my camera out, get everything set up. 11:55, oh, someone's gonna be at my door soon. Then the person would not. And forget trying to remember a name. You know, I've never met this person before, and I would try, like, Ann coming in. And she'd get to the door, gone, don't remember her name. And it was so frustrating. And when I had my neuropsych exam, I scored very poorly in short-term memory, but the neuropsychologist told me I wasn't trying hard enough. Like, no one would listen to me that I was having like these severe problems. Because I could walk, I could talk, and I looked fine. So those are my symptoms. So now I'll share with you some of my recovery and some of the things I did before I met Dr. Schmoe. So as I just mentioned, I had a neuropsych exam done. It was about 15 months into my injury. So I had gone to the neurologist at about 6 months, and she told me to give it more time. If I'm not feeling better, in 6 more months to come back. So I went back in 6 months, which was now a year. And again, you know, there's really nothing I can do for you right now. Let's just give it a little more time. 15 months I went back. I'm like, seriously, there's gotta be something we can do. Like OT, cognitive therapy, like vocational therapy, there's gotta be something. What can we do? Well, I don't know, it's over a year, you might not get any better. This might be the best it's gonna get. Well, I was here like 4 months ago. Why didn't we do something then? It was so frustrating. But she did do one thing for me. She sent me for craniosacral therapy. Is anyone here familiar with craniosacral? A few of you. So craniosacral therapy is extremely light touch. And you lay there for about a half hour, and it was a PT that administered it. And he was very, very comforting, and he would talk to me through the session, and he'd just kind of move his hands around my skull. And I think in the beginning I went 4 times a week, then 3, then 2, and then eventually just once a week. And the first 2 sessions, I was like, I don't know if it's doing anything. The 3rd session, I literally could hear the little tiny clicks in my skull, and the pressure just released. And that fog, I was living with like 24/7 fog, which he later explained was like pressure inside my skull. Just, it like lifted. And I only had one time where it kind of started to come back, and I went to him for 2 treatments, and it's never come back. So craniosacral was like the best thing the neurologist ever did for me. I had done yoga since college, and because of the dislocated sternum, I couldn't lift my arms higher than here, and my rib cage was twisted, and I knew that I needed to get back into movement, because I wasn't moving, I wasn't doing anything. So my yoga instructor helped me come up with 5 poses that I could do that didn't make me feel dizzy, and I literally would hold on to something, and this was my tree pose, if you know yoga. So doing this, that was my tree pose. But as I kept doing yoga, I noticed I was able to start breathing deeper. I got my range of motion back. I mean, I can now do tree pose on my own without holding onto a chair. So incorporating yoga, the breath, getting oxygen flowing through my body. I started doing some light weightlifting. Nothing with too much cardio, because my blood pressure would just spike, or my heart rate would spike. I cut out alcohol, and it was about 15 months into my journey when I realized how horrible alcohol is for a brain injury. It took me that long. And I would have a half a glass of wine or a half a beer, and I would just feel like crap the next day. And I was like, this can't be a hangover. I didn't even have a whole beer. Well, it was just my brain not able to handle the alcohol. And not to mention add alcohol to already not being able to balance and fall down. So I just cut alcohol out, and I still don't drink alcohol. It's just not worth it for my brain. Talk therapy, about 8 months into my recovery. Yeah, it was about 8 months, because I fell in February. Then that following October, when we started to get snow, I freaked out. And I didn't realize I was having a panic attack, and my doctor recognized it. I was like, you're having a panic attack. You're having PTSD. So he sent me to a psychologist, and he was fabulous. This guy understood brain injury, he understood chronic pain, he understood PTSD. I encourage everyone to find a great psychologist that you get along with. If you don't like the first one you find, try another one. And then this guy named Schmoe, he reached out to me. He had been reading my Huffington Post pieces, and he realized that I was local. We were both in Minneapolis. And he reached out to me and was like, hey, I think I can help you. Come see me. Okay, yeah, whatever. I blew him off for probably 2 months, because nobody had helped me. Nobody listened to me. Nobody believed me. So what's he gonna do different? Finally, he's like, just come see me. Let's do a consultation. Fine, what do I have to lose? So at this point, I was 2.5 years into my recovery. Not a single one of my symptoms had resolved yet. So I go in to meet Jeremy and had about a 2-hour exam with him. 2 hours, not 12 minutes, like your typical doctor appointment. And one of the first tests he did, he has a red and white striped scarf, and he's like, follow it with your eyes. And I was like, whoa, can't do it. He's like, yep, your eyes aren't working together. What did you just say? He's like, your eyes aren't working together. You believe me? He's like, yes, I believe you. Your eyes aren't working together. And so we did a week-long intensive after 3 days of working with him. This picture, they're exactly a year apart. So on the left is 1.5 years, on the right is 2.5 years. It's subtle, but if you look at my face, you can see the difference. I'm smiling in the left picture, believe it or not. So within a week of working with him, my dizzy balance had gone from a 9 out of 10 to 2, maybe 3. It was tolerable. My memory started coming back. My cognitive stuff cleared up. I mean, if I get really tired and fatigued or I overdo it, they still flare up. but I know the exercises that I can do on my own and calm it all back down. So now I'm gonna let Jeremy talk, and he's gonna go through how he helped me.
Alright guys, so I am a chiropractor and I have a diplomate through the American Chiropractic Neurology Board and I practice in Minnetonka, Minnesota. So we're gonna jump in and let's talk about the vestibular system a little bit here. So this is a great picture. It looks really complex, but if you break it down, your brain just really wants to know where your body is in space. So you take all the feedback from your muscles and you combine that with what your visual system is telling you, so what your eye movements tell you, and you integrate that with what your vestibular system tells you. So that information integrates in your brainstem, and it fires up into the higher cortical areas in your brain, and then it fires back down to allow you to be able to move appropriately and not fall over and be stable and know where your body is. So based off of Amy's symptoms, does it sound like she might have had an issue with her vestibular system? What do you guys think? Possibly, all right? Could it be an issue with her neck? Could be an issue with her neck, all right? Could it be an issue with both? Could be a neck injury, could be a vestibular injury. So really with my rehabilitation, that's what my examination, that's what I'm always trying to figure out. Is it a neck injury? Is it a brain injury? Is it a vestibular injury? Like what areas neurologically are affected? And then what can we do with your sensory systems to activate these areas of the brain to get them to integrate and function and work better and let people know where they are? And I can tell you also from personal experience from having a concussion, multiple concussions, when you don't know where you are, if you feel dizzy, if you feel rafty, if your balance feels off, that totally takes away from your energy. So your energy reserves go down, your ability to think and process and have higher cortical function really becomes affected. So the vestibular system comes in from the periphery. You have canals. You also have what are called otolithic organs. And the vestibular system lets you know if you're rotating, right? Also if you're tilting or going up and down or going side to side. And those pathways from your ear fire into your brainstem and then fire up into the brain. So we'll go through a little bit about why Amy felt like she was floating and rafting in a sec here. This is just a great chart that goes through how I think about patients and where to start. So I'd like to start at N. So the first thing here is nociception and noxious stimuli. So obviously Amy was in pain. So my goal with patients is to try and get them out of pain as quickly as we can. All right, if there's a cervical component, we're gonna do different therapies to try and decrease the neurogenic inflammation that might be occurring in peripheral nerves in the neck, figure out what provocative movements could be causing her pain. Also try and figure out, is this like a joint issue or a capsule or soft tissue issue? And what can we do to improve the structure? When you have whiplash, when you have trauma, there's changes that happen in the cervical spine, there's soft tissue injury, there's changes in the peripheral nerves and neuroinflammatory markers that develop. In some patients, you can actually go right into mobility and doing exercises and doing different body movements. You actually have to loop back up and go into the sensory system. So sensory systems, we look at like the cerebellum, the vestibular system, the basal ganglia, and that's what I was talking about previously, how your cerebellum takes gravitational load from your muscles, talks with your vestibular system, fires up to your brain, lets you know where you are. So if you don't know where your shoulder is or where your hip is, and they have pain in that area, it'd be a cool thing to activate those areas of the brain, let them know where that is, and then go in there and do some sort of structural care. Otherwise, the issue might just come right back. And that's probably what happened with Amy, is that she was getting structural care and craniosacral and these different things, but there was an underlying sensory mechanism that affected her vestibular system, and we had to do rehab with that first to get that better. Then all the other care that she had, craniosacral, or say if it was acupuncture, chiropractic, or PT, or whatever, it probably worked better if she didn't feel like she was floating and if she knew where her body was in space. Okay? So That's the system. We can either go up and do sensory and then start giving different types of body-based exercises that are more like neurological in nature, all right? And I'll go through what that means. All right, here's a picture of the inner ear here. So that's what I was talking about before. You have semicircular canals. Some of them respond to angular rotation, but you also have ones that respond to, do you feel like you're moving up and down or going left and right or tilting? And those are called the autolytic organs. Here, these are the longitudinal levels neurologically that we like to break down that can be affected with injury. So, you could have an issue with just a muscle injury. It could be peripheral nerve. Somebody could injure their cord. You could injure your brainstem. You could injure the cerebellum, the thalamus, the basal ganglia, or the cortex. So with concussion, there's linear, there's accelerational forces, and there's a lot of rotation that occurs. And midline areas in the brain seem to get affected. So those are going to be the midline cerebellum, midline areas in the brainstem, and the vestibular nuclei. And that's why people commonly feel like they're dizzy or rafty or floaty or feel rotation. It's not always an injury to the ear. It could be an issue with the brainstem and how the circuits integrate. Here's a great paper. Everybody should read this one. And it talks about how it's very hard to distinguish a physiological concussion from a cervical vestibular injury. And everybody's trying to figure that out clinically. Is it a neck injury? Is it a brain injury? In Amy's case, what do you guys think? Did it sound like just a neck injury? And to me, it sounded like a neck injury and a brain injury. And the areas that were injured were down in the brainstem because she had changes in her vestibular reflexes, ocular motor reflexes. So in my mind, it's not just a neck injury, and that's why the care that she got was probably good care, but it didn't get her back to 100% function. So let's talk about some of the things I was seeing on her examination. So when I saw her resting heart rate was at 110, and when she was standing went up to 115. So do you guys think that's maybe a little too elevated? All right. So what do you guys think of when you think of heart rates being that high initially? When you see somebody, I think of the sympathetic system firing too much. So with brain injury and the areas in the brainstem that get injured, people can develop what's called dysautonomia. So there's all these pathways from the brain, the cortex that fire down into the brainstem, and they actually fire down to regulate your heart rate, your blood pressure, and your gut to allow you to get better blood flow up to your head. So with her, if she's sitting there at 110, imagine what her heart rate would be if she's walking around or moving or getting overstimulated. So I like to equate that to basically, kind of running a marathon all day, right? There you go. There's some neurofatigue right there. Decreased rib expansion. Obviously, she injured some of the structures here. But you can also get decreased rib expansion, your ability of your ribs to move, if you have changes in your vestibular system and your eye movements. So there's a big integration between your eyes and your spine. And also all the way down into your intercostal muscles and the way that you breathe. So if your eye movements are off, it's common to see that people will have necks that are very, very tight, and their ribs are very, very tight, and their thoracic spine is tight. And for her, I didn't just jump in there and start adjusting her right away, all right? She had already had that done for, 2 years? So my goal was to figure out, well, what are the circuits that are off, and what can I do to allow her brain to know where she is in space? And what types of exercises can I do to start driving plasticity and improve her function? And one of the things that we noticed right away is when we checked her gaze holding is that her fixation was unstable. Has anybody seen that before with a patient? You bring your thumb up, you go, hey, can you keep your eyes steady on my thumb? And instead of keeping their eyes locked in, they look like they're doing some sort of oscillation or some sort of movement. And there's different areas of the brain that allow you to be able to fixate and keep your eyes steady. When I think of fixation, I think of frontal lobe. I also think the substantia nigra and the basal ganglia, and also the rostral pole of an area of the brain called the superior colliculus. Those areas can be injured, and they can affect how you keep your eyes steady on targets. All right, so that's an issue. If your eyes aren't steady, what's going to get tight? Usually your cervical spine. So if you're doing these movements all day long with your eyes, guess what? All the little intrinsic muscles of your neck are also making up for that, and they're doing the same thing. All right, so your neck's gonna get tight. And I see this a lot with patients. You know, they'll be in something like this, or they go to the mall, or they'll be in a car, and next thing you know, boom, neck just gets tight out of nowhere. They don't know why it got tight, right? They weren't lifting, they weren't doing anything. They maybe like picked up a pen and their neck blew up. It's because these reflexes aren't integrated and working appropriately. Next thing that we saw, she had dysmetria on her saccadic eye movement. So saccades are a fast eye movement that allow you to be able to move your eyes quickly and pick up a target. If, for example, I'm saccading over to the right, that's going to be more of a left brain activation down into the left superior colliculus, into the brainstem, to fire muscles to get my eyes to move quickly to the right. If I want to look up, that's a bilateral activation of the frontal lobe and the upper brainstem and the midbrain to allow you to be able to move your eyes up and down. So I always look for laterality of how people, look. Do they have a harder time looking to the left compared to looking to the right? If they have a hard time looking to the right, well, maybe they have something going on with their left brain. If they have something going on with their left brain, maybe I might see some cerebellar signs over on the right side. What kind of things might we see? Well, dysmetria on finger to nose, some DDK with their movement. They might be a little ataxic or fall over to the right. In Amy's example, we saw some dysmetric finger to nose on her left side. So she came in, and instead of hitting the target, basically dysmetria, so going a little too far. So when your eyes are trying to stop on targets, it's really your cerebellum that allows that to happen. So frontal lobe engages, the cerebellum stops your eyes on that target. Again, that cerebellar circuitry can be injured with concussion. Next thing that we did is we looked at her pursuit eye movement. So basically a pursuit is something like this. It's a smooth movement, it's not as fast as a saccade, and you should be able to keep your eyes steady on that target. And what happens with patients with TBI is that if they have poor gaze holding, they can't keep their eyes steady, they'll actually pick up a lot of the stuff in the background. And then that background contamination will give you a lot of the kind of symptoms that Amy had. So say if an object moves this way and the background looks like it goes like this, she might feel like she's moving.
Or when you wear plaid shirts.
Oh yeah. So that's a visual vestibular mismatch. And again, if your brain doesn't know where you are in space, your neck's gonna get tight. All right, your neck gets tight, there's all of this basically peripheral neurogenic stuff that can happen that can give you referral pain up into the head. All right, so with her, I think we palpated on Erb's point and also in the greater and lesser occipital, and I mean, she had referral up into that left side of her head. So Erb's point, right about here, everybody just kind of go touch that on yourselves right about here. Just kind of get in there a little bit. All right, there's a transverse cervical nerve, there's a supraclavicular, so you might have some stuff right above your clavicle. All right, there's a suprascapular branch, all right, and then there's also a lesser occipital branch that comes up. So I've seen people that have had pain up here, but really it's coming from down here. And we do some therapies to get their eyes steady, do a little bit of mobilization, go in there. We use a product called Prolo Gel. You guys might want to look that one up. It's called NeuroProlo Gel. It's a topical application that supposedly, and I see it work all the time, decreases neurogenic inflammation. And then when you go and repalpate, you might not see all this referral pain.
I used it last night.
Okay. All right, so one of the other things that we checked was we saw decreased gain on her left head heave test. You guys ever heard of that before? So with the vestibular system, your eyes want to move equal and opposite to what your head does. So if I go like this, my eyes should move this way. Makes sense, right? If I move my head down, my eyes go up. If I bring my head back, my eyes go down. All right, and those are the angular, those are the rotational vestibular-ocular reflexes. But there's also ones that are intraoral, and you can shift people's head left and right. And if you go like this, the eye should actually go like that. All right, so when we did the head heave test over to the left, move your head quickly over to the left, the gain of that wasn't appropriate. All right, so I see that and I think otoliths. The otolithic system is probably affected on your left side, and how it fired into your brainstem, but it was probably more central, because the more that we did that, guess what? It started to get better. The reflex started to turn on, the gain became normal, and it normalized over a 3-day period of doing activation into those pathways, so there's viability there, and you can make that function better. We also did a Fukuda step test. You guys ever heard of that one? You have people come up, close their eyes, start marching in place, and she was like all the way over to the right side. And you'll see that with people, and sometimes they rotate into their vestibular dominance, but sometimes they rotate into their vestibular weakness as well. It's totally different with each person, so you have to correlate it with what you see on your examination. So we have her close her eyes, just stand there, eyes closed, and she looks like this. Right? Doing things like this, you see the arms go out, it's called a cantilever response, and she feels like she's floating. When I hear floating, when I hear rafting, I think vestibular, I think otolus, I think there's something central that's going on in those pathways. So that was, that's what was going on centrally. There was a centrally maintained vestibular dysfunction, and we had to come up with therapies to drive those pathways and get them to improve. We also like to have people walk, and we look at their arm swing, we look at their stride length, we look at their ability to dual task, so we'll have you say every other month, every other letter of the alphabet, every color that you can think of, and we'll look to see if people like lose an arm, all right? So it'll look something like this. They're looking pretty good. They're like A, C, E. You see what happened there? So you'll see that all the time with patients. And if they lose the arm swing, I think, all right, maybe they're a little bit more unstable. If their arm swing gets better, I go, all right, well, maybe their frontal lobe has the ability to improve its function, and let's go in there and push them a little bit harder. So with examination, I'm always trying to figure out, well, what systems can we use? Can we use a body movement? Can we use an eye movement? Can we do more vestibular movements? Or is this system going to make somebody a little bit more autonomically unstable? Like what's the perfect recipe for that person to allow them to know where they are and get their system to integrate? We also noticed, so we do VOG analysis, vestibular oculography, graph out eye movements, and we don't just do all the stuff at the bedside, but we do diagnostics and we assess that. Her left eye looked like, when we were here, that it was converged in. So things weren't perfectly in motion there. All right, and then we checked her optokinetic reflexes, which is really a vestibular reflex. So if you bring this in front of somebody, it fires all the central circuitry in the vestibular system, and your brain actually thinks you're rotating to the opposite side. So if we bring it this way, your brain might think that you're rotating that way. If these reflexes get off, it's very confusing for your brain. And I've seen reflexes with people where you bring it one way, but the reflex is actually going the opposite way. And you think there's probably something going on with what's called velocity storage mechanism in the brainstem. And with Amy, you would just bring that reflex in front of her, and as soon as you would do that, symptomatic, dizzy, there you go. All right, do you think you get optokinetics all day long? I mean, I'm getting optokinetics right now, just like going like this. You got the weird carpet going on, you got the light, you do these things, and if those reflexes are off, that's gonna drain your energy. All right, you start draining your energy, you start becoming more dysautonomic throughout the day, your heart rate starts to go up, you become sensitized, your headache increases, you get more fatigued, and that affects all of the circuitry, and then there you go. You start moving around, your brain doesn't know where you are, you don't absorb force appropriately, you get pain in the neck, you get more headaches. We did pinwheel sensation on V1, V2, V3 on the left side of her face, and they were actually diminished on the whole left side. All right, and is that back now? Mm-hmm. You can feel it? Okay, well, that's good. All right, so when I think of that, I go, all right, what's going on with that trigeminal nucleus on that side? There's something that's going on in the brainstem, and if we're able to get it back, then it wasn't permanent damage to those pathways. And that trigeminal nucleus is a very long nucleus. It goes all throughout the brainstem, and it's right next to a lot of these vestibular nuclei and some other autonomic centers. So not only was your headache coming from something that was peripheral, but there was a central based mechanism to your headache. All right, there's all this circuitry in the brainstem that allows you to be able to get blood flow to your head. It's next to these pathways, so it wasn't just a peripheral mechanism that was giving you your head pain. And what I see clinically, and with a lot of patients with headache, is if their head feels like it's getting compressed in, a lot of times it's structural. If it feels like their head is exploding and coming from the center and going out, a lot of times there's dysautonomia. There's autonomic dysfunction that's occurring. So again, if it feels like it's coming in, you probably want to do some sort of structural care, whatever technique that you use, whether it's chiropractic or PT or mobilization, or you're a DO or osteopath or acupuncture or craniosacral. And with craniosacral, why might have that worked with you? It's just a very light stimulation that was probably activating your trigeminal system, all right, and then activating those circuits and making it work better. But it probably wasn't doing everything that it needs to do to fix all your eye movements and your balance and your vestibular system. All right, so here, that was all the Erb's point stuff that I talked about. We also saw a decreased gain on her left ocular counter roll. So take the head, if you roll it like this, the eye should counter roll back. It's not a huge response, it's kind of minimal. It's not like this where everything goes here, but if you go here, you should see some sort of counter roll. And with Amy, when you would roll her head to the left, it looked like to me that her eyes were actually counter-rolling opposite. So you'd roll her head this way, instead of going here, they looked like they went like that. So that's not normal, okay? So then I go, all right, well, what can we do to improve the counter-roll of her eyes? So if I go like this, it's actually superior muscles on this left side that cause your eyes to counter-roll. It's either superior oblique or superior rectus. With her, it was the superior oblique that we needed to activate it, so we just put her head in different ways and her eyes in different ways to put them in a mechanical advantage to help her eyes counter-roll. I didn't sit there and just go like this a million times to try and get it back. I turned her head to the left and gave her a couple yes yeses, and her eyes started to counter-roll appropriately.
And that was so hard.
Yeah.
That first day or two, it was so hard to do those exercises.
And honestly, like, your rhaptiness and your dizziness, we kind of fixed it with like one exercise. It wasn't 50 things. It wasn't doing all interactive metronome and D2 and NSI and gait rehab and stimming your tongue and chiropractic. It was one exercise that improved your ocular counter roll, and your dizziness got better and dropped from a 10 down to a 3 within a week. And commonly, in vestibular rehabilitation, a lot of people are looking at, obviously, this yaw plane and this pitch plane, but this whole plane here and this roll plane is kind of hard to figure out. It's very complex. So that's what a lot of my rehab is aimed at, is trying to figure out these complex counter roll and translational planes, because they always seem to be effective with the patients that aren't getting better. All right, and we'll just kind of pump through some cool research articles that you guys should check out. So this one did like DTI imaging of the vestibular nuclei in the human brain, and guess what? The vestibular nuclei talk to like everything. Dorsolateral, prefrontal cortex, cerebellum, reticular formation. So really, like, these vestibular nuclei in the brainstem, you can activate them not just by like shaking the head, but really, like, you could like move a hand, and that would give feedback into the cerebellum and fire into your vestibular nuclei. You could stimulate somebody's foot, you could stimulate their tongue, all right? You could do an eye exercise, you could even give them some auditory stimulation, and it's gonna fire those vestibular nuclei. And a lot of the patients that are like chronic, they have dysautonomia, they have these very unstable central vestibular systems. If you go in there and just head shake them and do things quick, they're gonna blow up. All right, they're gonna get headachy, they're gonna get very dizzy. So we like to kind of prime the pump a little bit. Might do a little bit of some hand movement, do some trigeminal stimulation, do some very slow, maybe like some barbecue rolls, even though they don't have BPPV, and try and do some very simple things to try and activate those areas of the brain. And that's what we did with Amy 3 times a day for 5 days. Here's a cool paper that goes through the video ocular counter roll clinical test to detect loss of otolith function Basically, they put on VOG goggles and they were laterally tilting heads and measuring their ocular counter roll of their eyes. So, write that one down, I think. Are you guys gonna get this PowerPoint?
Do you guys
Yeah.
like the slides? I think, I don't know how that works.
Check that one out. Here's the high frequency acceleration of the head heave test to detect otolith disease.
You know, too, I'm just gonna mention, we're gonna put our email addresses up at the end.
Yeah.
Email us and we'll send you the slideshow.
That is a really cool article that goes over the head heave test for assessing and looking for, well, symmetric and asymmetric otolithic dysfunction in the brain. And guess what? People get autonomic dysfunction after TBI all the time. And this is a really cool article that goes through the vestibular disorders following different types of head and neck trauma. That's actually from the Journal of Functional Neurology. I will check that one out. And basically, here's my approach to most all patients. So does the patient know where their head is in relation to gravitational inputs? So I like to check their balance, just having them close their eyes when they're sitting there and go, hey, do you feel like you're moving? If you feel like you're moving when you're just stationary there with your eyes closed, that's not normal. If you tilt your head to one side and they feel like they're moving, that's not normal. If they tilt their head to the other side, that's not normal. So I'm looking to see how their brain can take in this gravitational information. If they feel like they're rocking and rolling and they're rafty, well, it could be neck, it could be visual, it could be vestibular, and then you start pecking away and trying to figure out what systems are off. A good way to do that is doing like platform posturography. Have somebody on a flat surface here, and when you're on the flat surface, it's different than when you're on the foam, right? So you're on the flat, you're getting more feedback from your muscles. You go on the foam, you get less feedback from your muscles, and then you get more feedback from your vestibular system. All right, and do they have stable autonomics? So we're looking at heart rate, we're looking at blood pressure, we're looking at lying, seated, standing. I have a tilt table in my office, so we'll bring them through a tilt table test and see if their heart rate's going up above 30 beats and seeing if their blood pressure's dropping. Other types of responses can occur as well. Amy's heart rate actually went up when we brought her backwards. So it wasn't going up by 30 beats when we were bringing her up. We would get her up there, so it was already at 115, and then or 110, then we'd go up to like 115-ish. And then when we would drop her backwards, then it would actually increase. So I'm going, all right, what's going on with that? And I actually think there's a little bit of a traumatic PTSD component to this, because anytime we would like bring you into this position, your system, I mean, she was like shaking, she developed
I
like
started crying the first
tremors,
time, yeah.
So I think there was a traumatic component to that. But guess what? Do you think your vestibular nuclei fire into some of the limbic areas of your brain? Yeah, so like if you want to get neuroemotional help and psychology and these things to work more appropriate or work even better, fix the vestibular nuclei, and then she's having more stable inputs up into the brain. And there's regions of the cerebellum that are known as like the emotional areas of the cerebellum. There's whole books that are written about this stuff, the limbic cerebellum. And a lot of it actually integrates with like shoulders and hips. All right, so you start getting people exercising, moving shoulders and hips, and fixing their eye movements, and then emotionally they feel more steady, more stable, and their ability to take in the psychological work would probably work better. All right, and then we look at, hey, can I just put, I like to put people on just a swivel chair, and just start moving them. If they can't even tolerate that, I'm not going in there and doing a lot of quick head motion and head shaking if they can't even tolerate just being moved. All right, we also like to just put them in, I check all the canal positions, make sure there's no BPPV, but then I also move them through the horizontal canal in just a very slow barbecue roll and make sure that they feel steady in all those positions. So they should be able to feel pretty steady when you're just moving them around on the table. They should feel steady here before you move into doing your yes, yes, and no, no, and those type of motions. And then a lot of times the patients that we see have dysautonomia, so we like to start them off by doing rehabilitation on their back, get them stable on their back, and then move them through the tilt table, then start doing exercises seated, and standing, then walking, then moving. So that's the progression of what we try and take them through the whole week. Also taking into account what's going on with their cervical spine. and trying to decrease pain as much as we possibly can. So we use different types of manual techniques. I have a therapy, it's called arc wave. It's a type of direct current, and it has microcurrent background, but you can move the pads around and you can get a lot of blood flow going into these tissues, and you can start activating these muscles. And I can tell you from personal experience, and actually messing a lot of patients up, that you don't want to go in there all the time and just give them a huge adjustment right away. If they have dysautonomia, if their eyes are unsteady and their neck is tight because of compensation from the brain. All right, once you start getting these mechanisms better, then you might be able to go in there and adjust them, and you might not have to adjust them all the time. You might do 1 or 2 adjustments, and then those things stick and they stay because the brain's not compensating for an eye movement issue. All right, and then we do different types of just cortical activation. So say if, her saccades are off over to the left, I might do some left cerebellum rehab, some simple movements on the left. And from working with patients, you'll actually see that different movements will activate the brain in different ways and make people better or worse. So you might see like you move a figure 8 with the hand, and that might be different than doing like a concentric exercise versus even doing like a lowering phase, like an eccentric on one side of the body. That'll affect the brain differently, which is really interesting. All right, and then we start making exercises more complex, we make them harder, we start trying to get people to integrate into what they're gonna get in their everyday world, which is a lot of information. So just walk on the streets out here in DC, go down to the Capitol today, there's gonna be people everywhere in red, running in different directions, and if you had an optokinetic issue, you probably wouldn't feel so good. All right, so we try and make things really complex. I even take people outside. Well, I have chain link fences around our office. We're like running people around, and we're trying to make these exercises real because we don't want them to blow up as soon as they go out of our office. So they're fine in these 4 walls, but then they go outside and all their stuff comes back. So that's when we start building contextual training into their rehabilitation. Let's go through some of the stuff that we use. So I use interacoustics, VOG, to graph out eye movements. We use another device called saccadometer. Have you guys heard of that one? So it just graphs out latency, velocity, precision of saccadic eye movements. It's from a company called Ocular in Poland. We use iPads to do gait analysis. We graph people's gait out, which is very cool. Motor, sensory, reflex examination, all the structural examination. We do all that, very detailed history. We use Cadwell SSEP diagnostics for actually doing rehabilitation. So we might stimulate like a median nerve or a tibial or peroneal nerve, not for looking to see if there's a peripheral nerve lesion, but for just giving feedback to the brain about where like a hand is or where the head is. We do platform posturography on patients. We use Dynavision D2 diagnostics to look at people's reaction times. Yeah. We use the neurosensory motor integrator, the NSI, not only for diagnostic, but for rehabilitation. We use interactive metronome. Some other therapies that we do, we're doing photomodulation. We're using the Erconia FX365 for shining light on the head. We use arc wave. It's a type of electrical stimulation. And we run labs on everybody too. So with our lab work, we're looking to see, is there anemia, is there infection, is there elevated liver enzymes, is there anything that could be going on underlying? Because guess what? I mean, if you had anemia, if you had some other major metabolic issue, do you think their brain's gonna recover? All right, so you might be going in there and doing all this rehabilitation, they're not getting perfusion, they're not getting oxygen. So we run labs on pretty much every single person that comes into our office, and we do gut health protocols after we do all of our work. We do nutrition, we do supplementation with most everybody. Not everybody needs it. And this is an article that goes through the functional medicine approach to TBI. So we take a look at that one. And we also do an omega-3 protocol for brain health. What's that guy's name again?
Dr. Michael Lewis.
Dr. Michael Lewis, when brains collide. So we use his omega-3 protocol with patients.
He's local too.
And it's from DC, right? Okay. And that is everything that we do. So here's some resources that Amy put together. We have a Brain Health Online Summit. So 2 years ago, we put together the first Brain Health Online Summit, and quite a few people signed up. This year was even bigger, and we're trying to bring in all the best speakers, not just from chiropractic and functional neurology, but everybody. So inclusive of everything. Anybody that's doing cool work to help people get better, we wanna connect with you guys. So thank you.
One more. Yeah, that one. Has our, yeah, doesn't that have our email?
Yeah.
And it has our Twitter. You can find us. If you email us, we'll get you the slides. Make sure you guys got them. Any questions?
Yeah,
Plenty of time
questions.
for Q&A.
Yeah.
What supplements are you guys, I know, I'm just curious what supplements you're using. I know you use Omega, I know you draw labs, but are there
Yeah.
certain things that you use a lot for your concussion patients, or more often that you go to?
Turmeric, resveratrol, alpha-lipoic acid, CoQ10, things like that, yeah. Vitamin D, fish oil. Yeah, I use Zymogen, it's a company. I use Apex Energetics. I've done all the Apex Energetics courses, those are really good. Zymogen has really good functional medicine courses too. So, but here's the thing, if you don't get these sensory systems and these vestibular systems better, you can do all the supplementation in the world, and it's not gonna, resveratrol's not gonna go into the left vestibular nuclei and activate it. So, but if you're trying to work somebody up here's an example. I was working on this hockey player whose homocysteine was 98. And things like that, you're like, all right, normal marker is 0 to 15, you're inflamed, your triglycerides are at 1200, your TPO antibodies are at 500, right? So you can, even patients like that, you can still get them to feel more steady and balanced over a week, but then there's just a lot more work that you're gonna have to do in the long run to get them stable, because usually their symptoms are like this. That's what you see with autoimmunity.
And I had my blood work done just through my GP. Every year you go for your exam, and this was the first year. All my cholesterol, my blood sugar, everything came back in the normal range. Like I've had high cholesterol for like 10 years. I've had high blood sugar for like borderline for several years. Like everything came back like really good this year, and I know it's from supplementing.
Yeah.
Just eating different too.
Amy is also working with my wife, who does like a lot of homeopathy and other things like that too. So,
When you first were talking about the barbecue roll, I think I missed part of the explanation, but
Yeah.
was it because there was no BPPV? It was more from like a habituation approach in a more static environment in supine versus having some of the cervical activation and sitting.
yeah,
Is
so
that why?
you do it super slow, and you just hold on to their neck, and they just try and let their neck totally relax. So the way that I see it is you're basically coupling the neck with the gravitational input into the otoliths, and it's just working centrally. So you're not like taking crystals and putting them back to where they need to go. It's just letting your brain know, hey, here's your neck, here's your eyes, here's where gravity is, and it works really well.
And are you having them stabilizing something visually, or is it just the active movement?
Just eyes closed the whole time.
Eyes closed.
Yeah, eyes closed the whole time, and you'll get people into positions where you will actually start to see different types of body movements that occur. You'll see people start developing gait patterns of movement, and you're like, man, that's interesting, because you're activating the brainstem when you're doing that exercise. And I do it super slow. I mean, I might take 5 minutes just to do somebody in a barbecue roll and do it in a way where we don't see any motion with them at all. And that right there will help a ton. So if I saw some sort of central vestibular dysfunction on the left, a lot of times I'll do that barbecue roll first, and then you'll go in and then you'll check saccades, pursuits, and those things will get better. You'll see convergence get better just from doing such a simple application.
And if it's to the left, you would recommend doing it towards that left side?
Towards that
They
left
want
side.
to go to the right?
Yeah.
Okay.
And what I've seen too is actually the speed of it matters. So if you do it say if you think there's maybe a hypofunction on that side, if you do it a little bit quicker, it'll activate it. If there's some sort of instability on a side, where people like move into that side, they're like, oh my God. If you do it very, very slow, it'll habituate it and calm it down. So the speed of the barbecue roll matters. Yeah. Right?
I have a couple questions about the technologies.
Yep.
Wade, why did you guys choose that?
Oh.
I know
Yeah.
they are strategic in how you can use that technology. Like
Yeah.
you have to pay the monthly fee and everything
Oh,
like that,
yeah,
so
yeah.
I shied away from it.
Yeah.
But
So,
It feels amazing.
so when I was growing up, the CEO of that company lived next door to my grandma and grandpa.
we had a name.
So
Fair enough.
I've been playing around with electricity, like activation since I was like 15. I mean, I've had that thing, and I played baseball, and I was warming up everybody on my team and using it. So I've had one for a while. So that's what kind of sucks, is that there's kind of a monopoly on that thing.
Yes, absolutely.
You know, in the future, there'll probably be other devices that are very similar that will pretty much do similar things for cheaper.
Yes.
Yeah.
So you use an iPad to assess balance and use a force plate?
So I use Vertec.
Is that the force plate or the
Yeah.
Okay.
Yep. But we use an iPad
Right.
just for graphing out just gait.
Oh,
So
okay.
so we'll have people walk.
Okay. And
You know, I'll even put markers on them too, and
Okay.
we'll have them walk, and then you can slow it down and look at like toe off and stride length and
Okay.
things like that. A really cool company is called Noraxon.
Okay.
For if you want to really get into graphing out gait, posture, and movement and things like that. Yeah. But it's nice to go cheap.
Yes.
You know,
Absolutely.
as cheap as you possibly can and get good information.
I have the app for the balance and I found that
Yeah.
it's not good. And so I think I'll have to
It's
look
like
for
Yeah.
force plate, but I thought you found a good balance app.
There's other, if you email me, there's other balance devices that have come out recently that are about $1,500
Oh,
that
okay.
give you really good, pretty accurate information. So, yep. All right. Thank you, guys.